So as some of you probably will be aware, UK NEQAS is not one organization. It consists of several different centers, which are all independent, and which do have specific competences. And we are situated all around the UK. If you want to quiz your geography, you can try to list the towns to the little pink squares on the map. And of course, when it comes to point of care testing, not all disciplines do offer EQA specific to point of care testing. But the centers you should be familiar with in point of care is, for example, Edinburgh peptide hormones, cardiac markers, blood coagulation. And we also have Diane here representing them today. Then clinical chemistry, also maybe better known as Birmingham quality, blood transfusion, hematology, and then microbiology and parasitology. So just sort of like a little introduction to really emphasize that we carry different competences and offer different schemes. Next slide, please. So when it comes to the webinar today, just to give you sort of a little overview of what to expect. So first, we will have quite a brief introduction. We'll cover general topics, such as what is point of care testing in the context of this webinar. What are the different settings for point of care testing? What are the different applications? And this will be followed by the panel discussion. So we will be mainly focused on sort of 4 topics, excuse me. And these are limitations of point of care testing assays, frequency of monitoring assay performance, commutability of control material, and then also engagement with quality assessment procedures. You can define point of care testing in many ways. So the one that I usually prefer defines it as medical testing at or near the site of patient care. And what is implied is that that site is outside of a laboratory environment. And usually it is performed by healthcare professionals, but they are more often than not laboratory trained. So they don't have specific training to perform diagnostic testing, as you would expect of scientists who work in the laboratory. And of course, point of care testing also covers self-testing by patients, but this is not something that we will touch upon a lot in this webinar. And if you click again, please, Jen. So there are also some other characteristics that are often associated with point of care testing that are not necessarily part of the definition. And that is that there is an expectation for quick turnaround of samples, so fast results. And that is also flexible, so it is available where and when needed. Next slide, please. And point of care testing can be performed in different environments. It could be at first point of contact with the healthcare system. So in the United Kingdom, this is referred to as primary care. So that could be the general practitioner or a pharmacy. It could be when receiving specialized medical care or secondary care, which is the accidents and emergency department, a hospital ward, a specialist clinic. Or it could be outside of the healthcare system, at home or at a workplace. And all of these environments do impact what potential challenges you will face to provide point of care testing service. And they are inherently quite different, all these environments. Next slide, please. Sorry, can I have the next? Okay, thank you. And also you can do point of care testing for different aims or different applications. You could be performing it for diagnosis or to support a clinical decision. Or you could be doing it to support treatment or care decision. And these two are quite similar, but they're still important differences, which is why I have separated them here. So, for example, supporting the clinical decision, that could be testing for cardiac troponin to confirm or rule out if a person has a myocardial infarction. And to support treatment or care, for example, that could be testing for C-reactive protein, when you're not necessarily understanding what infection exactly the patient has, but you're just looking whether or not it's appropriate to prescribe antibiotics for the patient. So slightly different applications. Or it could be done to monitor a specific marker, for example, glucose, INR, or it could be done to screen non-symptomatic patients, for example, as part of NHS health checks, or even for sort of public health concerns. If there's an outbreak, it could be deployed for screening. Next slide, please. So if we look at quality standards in point-of-care testing, then ISO 22870 is now withdrawn. And there is an expectation that if point-of-care testing is carried out in hospitals, clinics, or in any healthcare organization that offers ambulatory care, the standard to follow is ISO 15189. Next slide, please. I did want to sort of mention a guidance document. So this, I believe, is a few years old now. So this was more directed at commissioners and service leaders. And it was published by the Association of Clinical Biochemistry and Laboratory Medicine, IBMS, and the Royal College of Pathologists. And this is basically, it was made for NHS England. And so this is National Strategic Guidance for at-point-of-need testing. And this also sets out 11 recommendations for the delivery of point-of-care testing. Next slide, please. But when we come back to the ISO standard, then it, in very broad terms, set out requirements for management, for resources, and for processes. So when you're looking at management, it's your organizational structure, it's the policies, it's the control of data, records, and documents. For resources, you have the requirements for the personnel, environment, equipment, reagents. And for processes, it defines the requirements for pre-analytical, analytical, post-analytical, but also how do you review your processes? So what do you do when you have an incident or if the work is non-conforming? So all these requirements, of course, are quite difficult to meet as is. But when it comes to point-of-care testing, there is often another, like, additional concern. If you could click again, please, Jen. And that leads us back to the performance or the quality of the point-of-care testing assays themselves. So, of course, technology has come a long way. The assays have improved with greater sensitivity and specificity, but that sort of fundamental question about the quality of those assays does remain to a certain extent. Next slide, please. So when it comes to performing point-of-care testing, of course, the question is, why is this testing done in the point-of-care setting? What is the benefit to that setting as opposed to doing it using conventional laboratory diagnostics? And when it comes to the assays used, then these assays need to be fit for purpose and they need to benefit the patient. But depending on exactly why this testing is done in the point-of-care testing setting, it does not necessarily need to meet the so-called laboratory standard. And if you could click again, please, Jen. So the main concern here is if you are aware that these assays might have issues, then these limitations must really be understood. And the assay performance must be continuously monitored, because that is the only way to ensure the correct interpretation of results. So could I have the next slide, please, Jen? Okay. So this was our very brief introduction to this webinar. And now we move on to the panel discussion. So as I already said, we will be covering 4 topics. So first we have the limitations of the point of care testing assays, frequency of monitoring assay performance, then commutability of control material, and engagement with quality assessment procedures. And again, a reminder, if you have any questions, please pop them in the Q&A section. Please don't use the chat function because these will not be sort of addressed in the Q&A. So just use the Q&A section. So can I have the next slide, please, Jen? So to start off with, here is a microbiology example concerning the limitations of point-of-care testing assays. I have to say this is not connected to any specific patient case, even though I'm sure that this scenario has happened several times all over the world. But we have an example of a 73-year-old man who is presenting at the GP with a fever, severe cough, and chest pain. And at the practice, the following testing is done. So using a lateral flow device and an esophageal swab, there's testing for influenza and SARS-CoV-2 antigen, which the result is negative. And then there is testing for C-reactive protein using a benchtop analyzer, abatabinium, and the result is 70 milligrams per liter, which is intermediate. So first thing, of course, to consider is always, could there have been an operator error? But for this example, we will put that aside, and we presume that all the procedures were done as they should have, and there were no issues. And of course, it is quite obvious that these results are not very helpful when it comes to determining a care pathway. You have not been able to confirm any viral infection. You have not been able to get a good sense of whether or not antibiotics are appropriate. But if we sort of look at the combination of this testing and these symptoms, then, and we'll start with the lateral flow device, then there are certain limitations that are inherent to that assay that perhaps should have been taken into consideration. So first, with lateral flow devices, I'm not sure how many of you have had experience, but one of the major problems that you see when you compare lateral flow devices with other methods, especially with nucleic detection assays, is that they are a lot less sensitive. Again, of course, they're not all equal. Assays do differ depending on the manufacturer. But that is sort of a known limitation. But now when you look at this presentation and you see this information that is provided, you see that there is something actually that's missing, and that is the onset of the symptoms. So if you're testing for viral particles, and when you're testing for influenza and SARS-CoV-2 antigen, and that is what you are testing for, then the shedding of the viral particles is something that over time will decrease. And if the onset of initial symptoms was 2 weeks ago, then it is not so likely that this testing would turn a positive result, even if in fact the patient is infected with either of these common viruses. So that's one limitation to consider. And then another one is, of course, the sample type. So a lot of lateral flow devices are quite specific to the sample type. You usually have one, you might have a few. In this case, it's the nasopharyngeal swab. But if you look at the symptoms, which are more indicative of a lower respiratory tract infection, then you could question, is this sample type appropriate for this presentation? And again, with that in mind, perhaps this test was not in the interest of either being able to provide guidance on care or in the interest of the patient. Now, next, when we look at the C-reactive protein, no obvious limitations there, referring to either specimen sample type or the clinical presentation. There, the question would more be, is this device operating as it should? Has the performance of the device been monitored? Are you assured that you are getting the results that are accurate? Because an intermediate result, even though unhelpful, is not inherently invalid. So this was my very microbiology focused case. And I would now like to invite my fellow panelists, in case you want to sort of bring any examples from your fields about any limitations to point of care testing assays that you perhaps face or have come across.
I think, Mary, I would just say that from the EQA provision point of view, many of the tests that I look after are finger stick procedures, and we have no way of checking that somebody can do that. That's not part of what we can provide as EQA. So there needs to be good training and competency in place for obtaining the samples, because it is very different.
Yeah, I mean, of course, that can always be an issue. Finlay?
I think there's different angles again, despite the fact that point of care is meant to be sort of a discipline independent and agnostic. There's certainly different ways that the different disciplines approach things, and maybe perhaps some of the chemistry things that are a little bit further on, where the idea of where things are being placed, all of those decisions have been made already, and it's much more, slightly more mature, and it's a question of making sure that the tasks that are there are done correctly and properly. So often we're talking about, and I'll mention it in my little slides, you're talking about urine dipsticks, for example. You might be talking about, as you mentioned, Marit, you might be doing things like health checks in the community, looking at lipids and things. So it's a little bit different, but I'm happy to keep my powder dry, and people can ask questions when I come to my little bit, if that's okay.
Thank you. I think we can have the next slide then. And the next topic is the frequency of monitoring assay performance. And perhaps first, Diane, do you want to talk us through of the different modes available, so EQA versus IQC? And then if Finlay, you have further comments on the topic as well. Thank you.
Okay, one of the questions we often get asked is, what's the difference between external quality assessment, EQA, that we provide, and IQC, which is internal quality control? And I always like to think of them as two pieces of a puzzle that fit together to provide a robust testing service. And the short answer is that you do need both. You need EQA and you need IQC. And this is what you're seeing on screen is actually a poster that the Working Party group have put together, and it's available to download from the NEQAS website. So you can print it up and stick it on the wall. You can circulate it to the wards if you want. And there's also a simplified version that you might want to use in ward situations. So basically the EQA is something that is provided from an external organisation such as ourselves. It's nothing to do with the manufacturer of the device or the test strips. It compares your result to others testing a similar sample at the same time, and it's really asking the question, are my results the same as everyone else's? It comes at set times in the year that we stipulate those, so you don't have any options when to take them, really. Well, certainly from our scheme, that's the case. Whether the other guys have got different options. You do the test, submit the results, and then you get a report following that up. So that's the EQA, and it's almost like a spot check. So most of ours run either every 3 months or every 4 months. So it's a sort of a window on that day. How are you doing? Whereas your IQC is something that you're in charge of as testers. It's purchased usually from the manufacturer of the device, and you decide when you're going to test it, and you decide how you're going to react to it. So you should have SOPs in place that tell you when to test. You should be fully trained in how to test, where to record it, and what to do if the result is outside of the range. So everybody should know where the IQC and EQA results are stored. And if you just you're coming on shift, you want to do an emergency test, you should be able to very quickly check that everything's up to date and that the machine and the test strips is fully working. So I wonder if Marit or Finlay have anything they want to add to this sort of overview of the two arms of QC.
I think that the underlying message I think that comes through from point of care is there is not one size fits all. It is a variety of things. And I wish it weren't so, but it is. So the different disciplines have a slightly different tack, different schemes have a different tack. What individual customers and participants want to do is different. So Diane mentioned the frequency for some of the coax things. We have schemes, for example, where in laboratory land, it tends to be monthly 3 specimens. But in point of care land, we think it might be a little bit less frequent than that. But some of our point of care guys do want it as frequently as that. And I think that's a bit overkill, perhaps. And some of them we might have 2 samples rather than 3. We in chemistry don't like the idea of doing a single sample, but for other disciplines that might be sufficient. So we try and do a 2 sample event, and whether or not that is a monthly event or a 2-monthly event or a quarterly event, our personal preferences, we don't want anything less frequent than quarterly, but we know that time is money and is trying to do everything to fit into what we're trying to achieve. So our sort of default position perhaps might be 2 specimens every 2 months, but that's not hard and fast rule. And again, it is horses for courses. It may well be that Marit's got some angles on what the microbiology angle is. And again, maybe it's to do with the throughput of the tests you get and how rare the testing is. Is it something you're running in your clinic every day, or is it something you run periodically? So there's lots and lots of angles. So I'll pass on to Marit for further comment on this, please.
I think the main things which are quite microbiology specific is that some of the testing, which is often done in point of care settings, is highly seasonal. So of course, depending on the operation, the sites can be different, but you might even be looking at sort of decommissioning your platforms and then recommissioning when sort of the winter season kicks off. So we do try to keep the seasons in mind. We try to have a distribution before, during, and after. But of course, obviously, happy to take any feedback on that. And also another, perhaps a feature is that very often it's combined testing. So we don't usually get away with sending 1 or 2 samples because we quite often have several targets to cover. So for example, respiratory viruses, which is very seasonal. You would normally test for 3 viruses. I mean, not every site will test for all 3, but these are the common ones: RSV, flu, and SARS. So if you already need to put 3 targets into your panel, then we usually start our panels from 4 and go up appropriately. So that's perhaps something from microbiology point of view. If using these single-use lateral flow devices, which we do see our participants using, then you cannot do a patient sample and IQC at the same time. So then you do have the question, do you check the batch? Do you check at a time interval? So again, these are, you know, quite operational. This depends on your facility, on your setting. But it makes it very difficult to sort of have any one rule. But of course, we do hope that, because in our EQA schemes, you can see the peer group. So also comparing your performance with that of your peer group, it becomes quite important when you cannot quality control a single device. That's what I would say.
And for the IQC, I think, as Finlay says, it's very dependent on your work pattern, what you are doing in the centre, because I've got INR testers who might be doing 100 tests in the morning, and that'll be a very different IQC approach to somebody who's doing 5 tests a week. So it has to be tailored to suit each user, each end user, and it will be different. And you'll need to figure that out yourself, and we can give some rough guidance if you are struggling on that. So I'm going to mention commutability of the control materials that we provide. And as an EQA organisation, we want to provide samples that are as close to the patient's type as possible. And we call that good commutability, and that's what we always aim for. But it is a challenge with point of care. As I mentioned earlier, some of our tests are done on, for patients, are done on native whole blood straight out of the finger as a finger stick. There's no anticoagulant. We cannot provide that as an EQA material. It's just not feasible that we could provide anything like that for 3,500 testers to test on the same day. So we have to do the best we can. So I'm going to illustrate this with the INR program, and just for a brief background recap, the INR stands for International Normalized Ratio. It's a test that we use to adjust the dose of vitamin K antagonists, which are anticoagulants such as warfarin. And the warfarin effect is very variable between patients. It's definitely not a one size fits all. So we have to have tailored therapy for each patient. And it can also be affected within that patient depending on what other medications or supplements or diet they are currently taking. So we need to be able to test, and we need to be able to adjust the dose and also adjust the frequency of testing. So again, the advantage of point of care testing in an INR setting would be that the majority of patients that I've spoken to prefer to have a finger stick sample than a venipuncture. They like the fast turnaround time, so you can sit with a patient face to face and adjust their dose, maybe adjust their recall, and you can make sure that your point has got across about the dosage change, rather than just posting it out and they don't find out for a couple of days, and maybe if they're a bit confused or concerned about new changes, they've got nobody to talk to, whereas in a face-to-face setting you can really get those things ironed out. And of course, as Marit already mentioned, we can do it in various settings, hospitals, GP surgeries. We can do it on specialised wards. We can do it in dental practices when it's not really to adjust the dose, but it's just to check that the dose is suitable for any procedures. And we can do it in patients' home, either self-testing or a health visitor going out there and checking their INR there and then. Next slide, please, Jen. So I mentioned commutability, and we are aware that our samples are very different from how you obtain a finger stick. And I mentioned that earlier, that we need to be sure that everybody's competent and fully trained in achieving that sample. So this is what our samples look like. So we have 2 vials and a little disposable pipette. One vial contains anticoagulated lyophilized plasma, so freeze-dried plasma obtained from patients on warfarin therapy. The other vial contains a pre-measured amount of diluent that we're going to use. We're going to add it to the lyophilized plasma, swirl it gently, wait 2 minutes, and then we're ready to test. So up to that point, it's quite different for our end users to what they're getting their finger stick. They've got to mix vials using my little pipette, make sure they use all the liquid. There's timings to be considered. But once we've got that to a liquid state, then the machine sees it as a patient sample. So it's seeing that clotting forming within that test strip, it's analysing that, it's deciding on an endpoint, it's calculating the INR, and it's producing a result. So as far as the device is concerned, the mechanics of the device, the way it measures the INR, is being fully tested. Next slide, please, Jen. So here I've got some results from one centre in our programme. So we've got about 3,500 devices that get checked en masse 4 times a year. So this chart is showing you deviation from the median. So the median is the optimum result, if you like, and that's the 0 line. And then the grey band of shading around that is what we have for our acceptable limits, which we deem to be 15% either side of the median. And you can see for the first 3 readings, they're within the acceptable. So that covers about 9 months, because I said that 3 monthly, and then the latter 3 tests are outside the range and they're all reading high. So for the latter 9 months, the EQA was reading too high and they would have failed their EQA for this. Next slide, Jen, please. So for this centre, we contact them because they've got 3 on the trot poor results. So we contact them and ask them if they need any help, any repeat samples to discuss it, to discuss their technique of EQA, if they're having any problems with sample testing. And the feedback I got was that the first 3 results were the original operator, but now that lady's retired and they've got a new member of staff taken on this task, but they have not been trained to do EQA, and frankly, it's showing in the results. But this, again, is over a 9-month period, so there has been time to train that person, but it's not actually happened by the look of it. So we sent some repeats, and I suggested that they followed the instructions carefully. With our samples, we always send pictorial and written instructions. There's a video you can watch on our website. And the instructions are quite straightforward. As I mentioned earlier, you add the liquid to the powder, wait 2 minutes and test. So following this advice, they repeated the test and they found that it was within limits. Next slide, please, Jen. So, and since that time, I've had a little look at this centre and they're doing well, results within acceptable range. So we concluded from this that the operator technique had resulted in inappropriate results. We didn't have any concerns regarding the device or test strips, but it does highlight that EQA can't always mimic the patient process. The problem with this was the operator not following the instructions, and the feedback I had from her when I spoke to her was that she didn't have time to read the instructions. She just threw it together and tested and hoped for the best. And that's not a very scientific approach. And sometimes we do get this with endpoint users who have not been laboratory trained, and they kind of panic when they see little vials and bottles and pipettes. And we have to bear in mind that it's only something they're doing every 3 months, so it's not something that they're overly familiar with. So what we want to provide EQA is a way to test your devices and test strips, and if they follow the instructions, we're able to do that. But as you've seen highlighted here, that if you can't follow the instructions, it does highlight in the results, and it can show up staff competencies issues, training issues, and then the point of care teams can focus in on that operator, give them the support, give them the tools to make sure that going forward we are just checking the devices and not their ability to actually perform the test. So that's a roundup of my commutability issues, the biggest being that we cannot provide native whole blood from a finger stick. We have to find some other way, and we use lyophilized plasma. But I don't know what the rest of the panel think, how big a problem commutability is to you guys.
Just because I'm a biochemist and we're a bit of a dull bunch, I was involved in the IFCC, the International Federation of Clinical Chemistry, commutability groups, and there's a whole series of work that we've done to do with laboratories. And I think the key message is not the fact I'm trying to show off. The fact is that when it came to trying to work out what to do with point of care and whole blood devices, that was not last in the list because it's very, very difficult to do. So even now it's just really sort of kicking in. So the laboratory side of things is well documented, and there's lots of boring stats to try and prove things. But we're in a different ball game here. We're trying to show that sort of single devices, one-off devices that you can't check again, how do they work with something that is designed for a warm whole blood sample when I'm sending out some sort of cold matrix through the post here. So it's a very, very difficult game to try and to play. But by and large, all of the scheme organizers sending out these specimens, they are making sure that whatever you get is the best possible that we can achieve given the limitations that we have. So it might not be absolutely perfect, but you could be rest assured that all of the different centres around the UK NEQAS sort of consortium are doing their very, very best to make sure what you get is the most applicable and appropriate specimen type for you.
I would just maybe bring in one example, which is again from respiratory virus testing. We have a case of assays that use different samples. So a lot use swabs, but then because pediatric patients are quite important patient group, you also have assays that might use an aspirate. And as we try to do, one scheme that would work for all of these different assays, then what we've ended up with is liquid samples. And for anybody who uses swabs, we ask them to essentially treat the sample as the site, our EQA sample as the site where you would take the swab. So, for example, use it as a nose. So if you have a swab-based method, then dip the swab into the sample. But yes, this is sort of a compromise that we've had to end up with. So that's the only thing that I have to add. And I think we can do then the next slide. And Finlay, over to you.
Okay, this is just an example. It's quite an old example. I think this is one of the issues we're going to mention. We want to try and make the reports that we send out to be as usable and user-friendly as possible. Now, historically, we've been sending out sort of A4 type reports. Now, admittedly, they're a lot more colourful and a lot more intuitive than perhaps some of the laboratory-based ones are, but they're still in a sort of regular A4 size. The future may well be that we're doing things just on a smartphone, sending things out of that ilk. But the problem we have is that we're already cutting down the amount of information we feed back, and sometimes if you were to hone that down even further, there's less sort of valuable information. It's not just a yes or did I get it right. And for most people in the sort of biochemistry land, again, I apologize for taking this angle, often there are networks of people that you have to deal with, and it's looking to see if the quality of work across the piece is well. And you might have, I don't know, 20 or 30 or 50 laboratories, or sorry, the sort of devices that you're responsible for. So the big picture is just as important as the small picture. But what I will do, I'll quickly, just as a very, very brief one, looking at this style of report, the key message is it is not full of dull, boring statistics. It is very colorful. This is for a urine dipstick. And again, if people who do this for a living, they will know that each individual brand of dipstick is different. The different manufacturers have different analytes in a different order. The time it takes to do the analysis is different. Some are at the same time point. Some you have to wait a couple of minutes to do things. So there's a whole variety of different things that can happen. So, but what we've tried to do here is to look and see what a visual representation would be. And if I move on to the next slide, perhaps, if we could. So just a slightly bigger trace, right? If we just look in the center, we can see that we've got the results there. You've got what your result was, what the consensus was, and whether or not you were spot on. And again, I make no apologies for using non-scientific language. I'm using a green diamond to say that you were on the money, as it were. And then you can be a little bit low with the yellow triangle, a little bit high, or very low or very high. So it's very, very simplistic in the way we do things. can I actually go back a slide now? I know that I'm probably annoying the guys at central office doing things, but what we have here is not only do we have the two specimens, the sort of specimen A, specimen B here, but we do a recent performance as well. So Diane kindly showed a graph with some cumulative data. Here we've got something that's just described in words. So we've got, if you can just about see that under the recent performance, it says this time you got a high result for that one, but we're spot on for the other one. And what's your recent trend? It's okay, but it's deteriorated, or is okay and getting better. So we try and emphasize things not only in the words, but there is some basic, very basic traffic lights to the side. So you can see by and large, are you green? Are you yellow? Are you red? So it's the standard RAG rating you've got. There's a little bit of words, a little bit of encouragement. So you can see you're getting better or you're getting worse. Can I have the next slide, please? And again, one of the things that, oh, I was going to talk to my second one, don't worry. Just a little bit, I've got some pie charts. So this is some old data. I was trying to find some data that was bad, but I couldn't find anything recent that was bad. So I had to go back quite historically, which is a good thing that people aren't messing things up. But I've got here sort of spreads of results for glucose. Top right, there's a pie chart, 72 responses. What did you think the amount of glucose was? And the issue with that is, although most people gave that the plus result, and again, there is a subtle difference, and you may not know a plus and a 2+ are different vocabularies that different manufacturers do, and they are not interchangeable. The amount of glucose that a plus is for someone is not the same glucose as a 2+ is for someone else. Now, that's completely counterintuitive, but it's something you need to know. If your buying department has decided to go for a cheaper stick and it's different and you're not used to this. So we have a situation where the majority of people get the right result. It was quite a lot of glucose in there. But there were some people that were way over the top. They thought there was a plus, as it were, result at greater than 111 of glucose there. But there was also a couple of people who had the result as being trace, and there was so much glucose in here. I'd hate to think that you would be missed and get something as a badder result as trace. So anyway, we can break things down, and if we move on to the next slide, it's what it might be, what it looks like for a different set of tests. So this would be, I don't know, a whole blood test, and I will move on to the next slide because it's a bit more detail. And we think that, again, the key word in the slide I'm talking to is called word engagement, and it's making sure that you as a recipient of one of our tests know what it means and can explain it. If you're a quality or a point of care coordinator, you might have to talk to people. If you're the end user, you need to see it. So it has to be delivered in a format that you might be comfortable with. So we've gone for the old favorites. We've got a red cross if you've got the result wrong, green tick if you're on the money. And you can see here just the ranked results. We've got a situation where on the x-axis, that's the bit at the bottom, we've got 154 results. There's a big tranche in the middle who are green are doing okay. A couple of bands of yellow where things are not too bad, but not wrong. But there are some red results there, which in reality, that you might classify that as being, I don't know, the wrong answer. It's certainly out of consensus. And depending how you set your limits, you can be as stringent or as wide in what you accept. But what we do have as well underneath that, we have the history, so you can see what you've been getting recently. This is way back. This is 2018 data, but it's the idea. You have two specimens. In this case, this participant got 2 green ticks for their total cholesterol, but for their HDL cholesterol, they got 1 red cross and 1 green tick. And again, you need algorithms to work out, does that mean you should be failing, should be castigated, or is it just you should have a little bit more look at your training, at your technique? But what happens if you've got lots? This laboratory doesn't seem to be, or this individual doesn't seem to be able to get consistently accurate results for their HDL cholesterols. There's a bit of a history, a bit of a pattern there, and that's perhaps slightly worrying, given that in the majority of these EQA schemes that we're developing here for things like the sort of cardiac lipid health check type things, by and large, it is a single manufacturer system that we're dealing with. So it's not a variety of different machines. They're all using the same one. So there's no real reason to have results different to your friends, your mates, your colleagues down the corridor. And just on the left-hand side again, maybe, in fact, no, let's move on to the next slide. It might show it a little bit clearer. We have just on the top left there, we have the device details. We know which device was used. We know who the user was, and we know what batch number was used. And these things come into their own. Often, sometimes the end user say, "Oh my God, why do I have to fill in the batch number again?" Sometimes you can do it automatically. Sometimes you can say, "Was it the same as last time?" or whatever. But when you have problems, having this batch number details is crucial for doing any sort of investigations for out of consensus performance. So again, this is just another example. This is one for HbA1c. It's got a small number of users for this particular model. It's only about 13 users we have here. We know what the target values are because with lots of these things, we share the same material with our main laboratory scheme. So we will know that what number we're expecting. So it's not just the mean or the median of these 13 results. We know we've got a sort of 400 other results, and we've also got things underpinned by secondary reference material laboratories in the Netherlands, just to be a bit overkill. So we know what we're doing. But again, the engagement, we want to keep it simple. So do you have a green traffic light or not? If you've green, you probably don't have to worry. If you're red, it's not the end of the world either. But the key thing is you have to engage with us and engage with your coordinator too. I'll quickly go on to two more slides very quickly, if I may. We've got one here. This is what a point of care coordinator might get. And again, this was for one of the dipsticks. So we've got each column in this graph is a location. So we've got Ward 1 and Ward 2 and Ward 3 and all this sort of thing. And you can see for each of the analyte tests, what did this laboratory, or what did your group of individuals or locations you're responsible for got. And you can see if it's green, yellow, or red. And there's also a little trend arrow, so you can see, am I getting better or worse than last time? And you can count up the total number of errors and things. So this is the really strong, powerful information that you might not be able to get from any other source, even if you've got a rigorous IQC type system. This is a very, very valuable tool. One final slide I've got before the session starts. This was just looking at the whole thing. So this is, as we mentioned, it's got the specimens, the A specimen, the B specimen, but it's also summarized things for this rolling time window. How have you been doing over the last few months? No one's going to castigate you for getting anything wrong, but if there's a pattern over the last, as Diane said, over the last 9 months, things are going badly, you can see that and you can step in. And for most of the participants most of the sites you're looking after, most of them will be doing very well most of the time. And because you're so hard pressed for time, you want to be making sure you're focused down on those areas which things aren't great. Now, it may be it's the location that's the problem. It could be a ridiculously busy ward or something that isn't getting things right. It may well be that the instrument's stuck in a cupboard somewhere and the lighting's not very good. There's all sorts of local reasons, but you on the ground will know what those are. So that's a brief sort of overview into how to try and encourage engagement between us, the coordinator, the end user, to make sure that the data is presented in a way that's fairly readily understandable. No SD, standard deviations, 1/over reciprocals, or all sorts of stuff. This is green, yellow, and red, and there's not a little bit of trend arrows. And I think this is the type of approach that we've certainly used for a long time. And I think other people have got something similar. They might not be exactly the same, but the broad thrust of what we're trying to achieve across the piece is similar.